Hello everyone, my name is Nicholas Grubik, and today I'll be sharing with you our study entitled Bystander-initiated CPR and AED use after out-of-hospital cardiac arrest, uncovering differences in care across the urban-rural spectrum. And I have no disclosures. So it's well known that the initiation of bystander CPR and the use of an AED improves survival outcomes in out-of-hospital cardiac arrest. And evidence has suggested that for every minute without treatment after a cardiac arrest, the chance of survival decreases by 5.5%. When investigating the overall rates of survival to hospital discharge with favorable neurological outcome, only around 8% of arrests in the United States actually achieve this outcome. And importantly, prior research has found substantial regional variation in survival within the United States, ranging anywhere from less than 1% to an excess of over 20% based on the area investigated. Although previous studies have noted poorer outcomes after cardiac arrest for rural areas, there's currently a limited understanding of how bystander interventions impact survival outcomes across areas of geographical diversity. Given the unique systems of emergency care for regions across the United States, there's a need for further investigation on the differences in cardiac arrest care and survival across the urban-rural spectrum. To this end, the objectives of our study were to compare the provision of bystander CPR and AED use in areas along the urban-rural spectrum, as well as compare the effect of bystander CPR and AED use on survival with favorable neurological outcome along the urban-rural spectrum. So for our study, we conducted a retrospective cohort using the 2013 to 2019 annual cycles of the Cardiac Arrest Registry to Enhance Survival, or CARES for short. And CARES encompassed a catchment area of about 140 million individuals across the United States. And our study population included all adult, EMS-treated, non-traumatic out-of-hospital cardiac arrests in CARES communities. So looking at the sample selection flowchart on the right, after applying our exclusion criteria, the vinyl sample eligible for analysis was around 325,000, and approximately 24% of our cases were missing data for certain covariates. Therefore, all regression analyses conducted were run using a complete case analysis, thus excluding any cases with missing information. In terms of our conceptual model, we were specifically interested in the relationship between bystander CPR and AED use on the primary outcome of survival to hospital discharge with favorable neurological outcome, which we defined as a cerebral performance category of 1 or 2. And to examine the effect of bystander interventions across the urban-rural spectrum, we used a 5-level classification system to define the location of the arrest. This classification system was derived from the Rural Urban Commuting Area Codes, or RUCA codes, which have been standardized by the United States Department of Agricultural Economic Research Services. And following health research guidelines and recommendations, we consolidated the RUCA codes into 5 distinct categories to represent areas along the urban-rural spectrum. So the following figure shows a sample US county with the 5-tier classification system, as well as the location of EMS agencies and hospitals in this county. So in general, urban areas, which are shown in purple, suburban areas shown in brown, and large rural areas, which are shown in blue, were more centered around primary care centers and emergency services, whereas small towns, which are shown in green, and rural areas, which are shown in red, seem to be more isolated from these services. The following figure displays the descriptive rates of bystander CPR, bystander AED use, and survival with CPC 1 or 2, according to the urban-rural status of arrest. We found that in general, as the location of arrest became more remote, bystander CPR, which are shown by the blue bars, tended to increase, although survival, which is shown by the red line, seemed to decrease. And throughout the entire urban-rural spectrum, bystander AED use was relatively low in all areas, ranging anywhere from 1.7 to 2.9%. And interestingly, we noted that large rural areas reported the highest rate of survival to hospital discharge with a CPC of 1 or 2. So to answer our second objective, we developed a multi-level logistic regression analysis where we clustered at the EMS agency level. And this allowed us to understand the relative effect of different bystander interventions on survival with CPC 1 or 2 based on the urban-rural location of arrest. In our model, we categorized the bystander response to a cardiac arrest into 4 distinct categories. And these categories were no bystander intervention, bystander CPR alone, bystander AED use alone, and the joint provision of bystander CPR and AED use. So the following forest plot represents the effect estimates of bystander intervention groups on survival with CPC 102. And all measures of effect were determined from a multivariable model where we adjusted for age, sex, race, income, etiology, the location of arrest in terms of it being in a public setting or a private setting, year, witness status, rhythm type, and EMS response time. If there was a significant difference in the effects of different bystander intervention groups on survival, then the confidence intervals would not overlap. Whereas if there was no significant difference in the effects of unique bystander intervention groups on survival, then the confidence intervals would overlap. So overall, we found that the effect of different combinations of bystander interventions vary considerably across the urban and rural spectrum. So specifically, the effect of CPR and AED use on survival was significantly greater than the provision of CPR alone and the effect it had on survival in urban, suburban, and rural areas. And this is indicated by no overlap in the confidence intervals, which is highlighted in green. And in comparison, in large rural areas and small towns, there seemed to be no significant differences between these two intervention categories on survival, which is indicated by the overlap of confidence intervals, and this is highlighted in yellow. So this suggests that large rural areas and small towns, within these settings, the addition of using an AED did not significantly improve the odds of survival in comparison to when just bystander CPR was performed. Overall, in our descriptive analysis, we found that as areas became more rural, the rate of bystander interventions increased, whereas the rate of survival after cardiac arrest decreased. And our regression analyses also demonstrated that the impact of different combinations of bystander interventions seemed to vary along the urban and rural spectrum. And these findings left us to hypothesize why these differences were present for certain areas along the urban and rural spectrum, and potential reasons for this variation in the relative impact of bystander interventions across areas may have been due to differences in AED coverage and access, potentially the number of bystanders assisting at the scene of an arrest, as well as differential knowledge in CPR and AED training, which is potentially due to limited training initiatives for areas outside of urban settings. And these factors should really be the focus of future research investigating urban-rural differences in out-of-hospital cardiac arrest. So in conclusion, our findings advocate for new guidelines and policies that should focus on the development of community-specific pre-hospital care strategies in order to improve out-of-hospital cardiac arrest outcomes in underserviced areas. And this approach differs from the one-size-fits-all approach to care that has been routinely recommended by national societies such as the American Heart Association. So overall, there were some important strengths of our study. So this investigation was the first epidemiological study to uncover differences in out-of-hospital cardiac arrest characteristics, bystander care processes, and survival outcomes using a multi-categorical urban-rural classification index in the United States. And in comparison, majority of other studies have used a simple dichotomous category, which tends to mask the hidden heterogeneity of different areas along the urban and rural spectrum. We are also able to utilize a comprehensive registry of cardiac arrest patients covering a large component of the United States in our investigation. There are also a few limitations which should be noted. So there were some confounders which we were unable to adjust for in our analyses, which may have influenced our findings, such as patient comorbidities, bystander CPR quality, bystander characteristics, and in-hospital factors. We're also missing information on about a quarter of our sample. And the main variable that was missing was EMS response time. And as a sensitivity analysis, we did perform multiple imputation to address missing this, which produced similar findings to our complete case analysis. And finally, not all United States communities participate in CARES. Therefore, we can't be certain that our results are generable to the entire United States population, although this registry does cover approximately 40% of the country. So we believe our findings can help guide policies surrounding bystander out-of-hospital cardiac arrest care within communities of varying geographical diversity. So finally, I'd like to acknowledge our data partner, CARES, as well as funding for this project from the Canadian Institutes of Health Research. So thank you all for listening. I would be happy to answer any questions.